When you're ready. Okay. I'll start then. Hello, everyone. This is about celebrating 10 years of the National Archive Center. It's a huge pleasure for me, given where we were previously. I will begin by remembering Robert Gregory, whose picture you see here. Robert was running an AKU website from his house in Liverpool when I first met him. He's asking me for something. Yeah, I've done that. So without going into too much detail, Robert Gregory, who suffered from AKU himself, established the AK Society formally in 2003 with myself, Kenneth Wall Atherton, Lord of Hurley, Whitley, Hercourt, and he was a patron and registered us as the founders of the Charity Commission. This was in 2003. I must say I was a little bit shocked this morning to learn that Ken has died. He passed away in February 2021. I suspect it might be COVID related. Anyway, almost immediately we had the good fortune, extreme good fortune, that Dick Sireau, father of two boys with AKU, joined us, and he's been the driving force since the start and takes a lot of credit to where we are now. There's nothing in the UK for AKU before we started for this orphan disease. Bob ran the website with help from me on medical matters, and this was mostly patient-relevant issues until the end of 2004. We had an unexpected opportunity to do a detailed post-mortem examination on a 74-year-old patient who died in the Midlands. Tim Helliwell, who's the histopathologist, carried out the post-mortem with me in attendance. I remember thinking at the time it was very strange that the AK pigment was so localized at the post-mortem. I then composed my thoughts and put together what I was thinking in this document, which was entitled The Investigation of the Nature of Ochronotic Pigment and its Interaction with Tissues, as you can see here. And you can see this is fairly early. This is early 2005. And I realized that the postmortem did not match up with what I expected in a 74-year-old AKU patient. And this gave us the direction and the starting point we needed to begin studying and researching AKU. It was at this time I was very lucky to meet up with Professor Jim Gallagher, and he invited him to join us and help us with the research. And I'm sure he'll tell you more about that when he talks about his experiences. During this time in the US, there was a group in the National Institute of Health who had proposed in 1998 that the drug nitisinone, already used in hereditary anemia type 1s in 1991, might also be effective in AKU, even though this initial suggestion was only a letter to the editor. It was a crucial advance. The NIH then went on to do 3 studies developing nitisinone from 1998 to 2008. The first clinical experience of patients receiving nitisinone was described in the New England Journal of Medicine, a prestigious journal, in 2002. And this was also, interestingly, commemorating Archibald Garrett, who had studied AKU 100 years ago in London. It was a centenary publication. And it was in that they described the first 3 patients to whom they had administered nitisinone. During all this time, when the clinical development was happening, I was thinking that we needed to be ready to provide this drug that was being developed by the National Institute of Health to all our UK patients. In fact, I remember Nick and I visited the Department of Health in London Waterloo, and we were unsuccessful in engaging with the DOH at that stage. The NIH studies culminated in a 3-year clinical trial, which began in 2005. We knew in 2009 that the study had not worked at an AQ conference in Sireau. Nitisinone was used as a 2 milligram dose at the time and decreased homogenic acid very nicely, as you can see here in this figure. The untreated group in the blue line at the top and the red nitisinone line at the bottom of the urine homogenic acid coming down very nicely. But unfortunately, they did not find a difference in the improvement in hip movement. during nitisinone treatment that they're looking for. And so the trial has been unsuccessful. So we're very disappointed with that. However, this gave us an impetus for our own research. We began to ask why the NIH study was inconclusive. We asked why it didn't work. We thought they'd used too few patients in such a complex condition, 20 on nitisinone, 20 not. We started to think how we could improve our numbers in the UK if we wanted to do a clinical study. The failure of the NIH study was because of lack of understanding of AKU, natural history, because of the slow progression, the multi-system nature, and we wanted to address that and have our own natural history study. We realized that the endpoint they'd used was not right. So we developed our own new endpoint. We took into account the totality of the AKU called the CUSI. And this we began developing. Even before all of that, we had come up with a strategy to identify AKU in the UK. Even in 2005, I fished out this email I had sent to Robert Gregory in July 2005, where I had sent him a GP questionnaire that I had developed for the purposes of patient identification. And you can see the questionnaire on the right. Basically, the questionnaire was about informing the GPs about the features of AKU, in other words, some education, but also asking them whether they had any patients and to tell them that there was a possible new treatment for alkapnuria. And after the NIH trial failed, this became a major focus for us. So between 2008 and 2010, we systematically surveyed all GPs in the UK to identify 81 patients and around in the UK and around 500 in Europe and over 1,000 worldwide. And that is shown in this slide. So you can see on the left top there, so we built a patient base, the GP survey was carried out. Our staff, you can see Bev Hebden and Janet Hignett there, attended conferences to find out from attendees how many patients they had and also to inform them about AKU. So if we had a patient with AKU, we screened the siblings. And of course, we were into GP awareness, as I've already told you. So we were funded by the National Lottery at this time, so about £220,000 that we got. And the map of the UK shows that the patients are dispersed all over, which is typical for a country where consanguinity is not a huge problem. So this is typically what you would expect. Equally importantly, in order to raise credibility, we published our experiences in how we identified patients in the UK early in 2011. Between 2008 and 2011, as I mentioned before, we started a natural history study of around 18 patients. It's crucial because it allowed us to think carefully about how to assess AKU patients, many of whom were not aware of the extent of their AKU. I identified and put together a multidisciplinary team to assess AKU patients and added to this when the NAC were formed later, which I'm sure Milad will be talking about. The assessment system also allowed us to understand how AKU evolved. It also allowed us a better way of working out whether treatments such as nitisinone worked by using this multiple score system to assess. And it was also then later on used as a performance indicator in the National Center once it was formed. Even though we had a small funding from the Chilbrick Trust, courtesy of the AKU Society, we didn't need to use it at all. So this is all about developing credibility. When I called for a new rare disease, the services came up in the NHS in 2011, very well set. We knew where the patients were in the UK. We had an assessment system that worked. We published this. We had surveyed patients about the lack of opportunity for acceptable care for their condition locally. And there's a potential new treatment, nitisinone. After a part 1 and part 2 application process, led by the Royal Liverpool University Hospital and the AKU Society, we were successful in having the National Alkapnuria Centre coming to Liverpool. I must say, I'd have to remember Oliver Timmis was a young Cambridge student at the time who was recruited by Nick. And he started in 2011, the year we had all the good fortune in terms of the National Centre and the European funding. And he brought with him good luck, apart from just starting with this during these times. And finally, I have to say thanks to Edmund Jessup, who was crucial in his advice and support for the centre to come to Liverpool and helped us get it right. He has since retired, and apparently he's studying a course on origins of war in Cambridge. As you can see on the right-hand side, we had the letter dated the 5th of March 2012 from the highly specialized services, which is called the Advisory Group for National Specialized Services at the time, that they had commissioned the service for Al-Capnia to begin in Liverpool on the 1st of April 2004, April Fool's Day. So there we are. So that is part of really what I wanted to say. And I'll finish by saying that we had a formal opening of the centre, which we named in memory of the pioneering efforts of Robert Gregory in January 2013. And you can see the usual suspects there. We had the CEO of the Royal Liverpool Hospital there, next to him is Nick, and then myself. And we had Kenneth Ward Atherton there, as well as Jonathan Jarvis and Jim Gallagher, along with, of course, Robert, who was quite ill by this time. So I will say thank you and hand over to Dr. Milad Khedr, our next speaker. Let me get out, stop sharing. There we go.
Thank you, Ranga, for a comprehensive presentation. I haven't got any slides, but there's just a few points. Building on the strength and successes we had over the last 10 years, we have a couple of issues to deal with now. Number one is building resilience within the NAC team, and I think this has been exposed over the last couple of years with COVID. We haven't been able to bring patient in, and we still had to look after our cohort of patient. So we had to think outside the box. We have to think laterally. For the first year of COVID, most patients, we only managed to bring 10 patients face to face. All other patients were reviewed on a virtual basis, and we've resorted to remote monitoring in terms of dietetic, deploying dietetic reviews over the phone, occasionally over the video, and also utilizing blood spot monitoring. Luckily, we're back on track now, but I think there will be still a role for virtual monitoring, whether it's telephone or video, and also continuing the blood spot monitoring or whatever a method of Tarzine monitoring we can. There's three options we working on. There's the Mitra sampling device, which has been slowed down by the need for validation and the fact that the lab actually has moved to the new build, but we haven't. So that's, and I'll talk about this in a bit. And we also have an aging cohort of patients. They travel far and wide to come here. And we realized that there has to come a point where actually these patients may not be able to do the journey every year, or maybe, I don't know. I mean, the patient would love to have the patient here every year, but that may be down the line, maybe unrealistic, maybe not every year, or maybe not at all. And it is no need to be, efficacy and safety need to be monitored. So that's something we continuously thinking about and how we can address it. But for as long as our patients can come in, we would welcome them. The other issue in terms of service resilience is transition. So the first transition we had last year is Shirley leaving the service after she's done a tremendous job over 10 years. and we managed to have a very smooth transition with Claire now on board and fully in charge from a dietetic aspect. Also, we had Emily and Helen. I don't think worldwide, I don't think there are nurses with the expertise and experience of AKU that Emily and Helen have. So it was really important to try and return them and keep them within the service, and also push them forward. And they've done lots of courses on diagnostic and physical examination. And they are now independent prescribers, so they can prescribe Vatiquinone. So I think this is this can only be beneficial in terms of service resilience, beneficial to the service and also beneficial to the patient, because you don't get this opportunity to be exposed to this environment, get to learn about the disease, and being closely involved in all the AKU trials. So it's really important that we keep them on, but also push them forward and give them more sort of patient-facing responsibilities. So that was an important thing. Lastly is it's the elephant in the room, isn't it? It's been hanging over us for years. Is the move to the new build. So this is going to happen between the 28th of September and sort of beginning of October. So the whole hospital is trying to find their feet with this move, and we're planning to go ahead with the visits. There's a pressure to cancel the visit, but we try, even if it's reduced in terms of investigation and things like that. But I think it's really important to try and go ahead with it and see and find our feet in the new place. There's lots of challenges, where the patient is going to be based, where the various departments going to be, and etc. So yeah, that's in short my bit. I'm happy to take any questions.
Thank you. Any questions, maybe from Brenda or Tony? No? Oh, we can't hear you, Brenda.
No, I was just saying I'm quite happy. Everything's really explained really well.
Excellent. Thank you, Brenda. Well, thanks very much, Milad. That was great. Thank you. And now I'll hand over to Jim, who's going to talk to us a bit about the research that's been happening at the University of Liverpool with the NAC. Jim, over to you.
Can you see that okay? Yeah, great. Okay, well, thanks very much for asking me to do a presentation. So I'm Jim Gallagher. I'm an emeritus prof at the University of Liverpool, and I'm going to just say a few words about the collaboration and synergy between what's happened at the University of Liverpool and the NAC. And so I've been working in bone and cartilage research for about 45 years. And the last 15 of that was initially in part on AKU. And then over the years, AKU came to dominate my research. And it's actually been, in some ways, one of the most exciting periods of research in my career because of the unique collaboration between basic and clinical science. So the journey into AKU started with these three people. I'm showing some of the slides now that are similar to the ones Ranga showed, but Ranga, I knew Ranga, and he contacted me because he knew I had an interest in cartilage and asked me to work on AKU. and I thought it would be an interesting side project. And then he introduced me to Rob Gregory, who was a great force in getting this research off the ground, and soon after that to Nick Sireau. And they raised a little bit of funding to start some research. So, as Ranga mentioned, the first research in AKU at the university was actually done by Tim Helliwell, who did this review of pathology on a cadaver that was donated. And one of the great themes of this research is how involved patients have been. And in fact, we've had 2 body donations. We had one more recently. And these have been influential in getting the research underway. And this is the sort of picture that's basically causes a lot of the issues in AKU. And so you can see that patients haven't just donated their bodies when they've died, but when patients have gone to surgery, they've let us have the tissue. And that's been it's led to a major understanding in the pathology and the progression of AKU. And you can see this black pigment, which is the characteristic pigment. So one of the early things we did, we found that that although we could see the pigment here, and this is a microscopic image, this brown pigment, that we could enhance that by staining with something called Schmoll stain. And it's been very important to us, and now colleagues all over the world are using this to make new finds about AKU. And that was actually discovered by a superb technician we had for many, many years, Brenda Vladarsky, who was a real leader in the technical aspects of histology. Using that stain, we were able to develop an in vitro assay to look at the ochronotic pigmentation. And that involved our first collaboration with Laura Tinty, who you can see here. And soon after that, our first PhD student, Adam Taylor. And it's quite remarkable how well a lot of our PhD students have done. I'll come on and mention that later on. Now, the assay was interesting, but it wasn't particularly useful because we couldn't test, for example, we could test inhibitors of pigmentation, but we couldn't really test inhibitors of the tyrosine pathway because, of course, the primary defect is in the liver. But with these pieces of tissue we got, I showed them to this chap, Alan Boyd, who is the preeminent expert on the structure of cartilage and bone. And he was just amazed, and he started working with us. Alan is, I think he's in his mid-80s now, and he's still working hard. And using his microscopical techniques, we found out a lot about how pigment is deposited in tissues. And this is one of the interesting things about AKU. Wherever and whenever we've spoken to experts in other fields, they've always become interested. And in fact, that's happened recently because we're now using a technique called Raman spectroscopy to try and monitor pigmentation non-invasively. And we've got some super scientists from the University of Liverpool involved in that. So basically, from our early studies, we learned 2 things that were surprising, I think. One was that this pigment makes the cartilage very, very sort of stiff but brittle. It's easy to break up. And also the pigmentation started at the lower surface of cartilage, whereas my expectation was that it would have started at the articular surface. And that's just some evidence showing that there's increased stiffness. I won't go into the details of that. And this shows that this macroscopic thing where we see the pigment starting in the lower regions of cartilage can also be shown microscopically. This is the first ochronotic cell in this cartilage, and then the ochronosis spreads to the surface. Okay, so this allowed us to develop a sort of hypothesis about the pigmentation. The tissues are initially resistant to pigmentation, and then through changes in the tissue, they become susceptible to pigmentation. The HGA, which is interesting because no one's mentioned it yet, although it's the culprit molecule in AKU, is deposited in the tissues. It changes the tissues, and then that allows more pigmentation. And of course, this pigmentation of the tissues is the cause of the main pathology in AKU, the joint destruction, etc. And this is a little scheme we made of the joint destruction. So that's a healthy joint, hyaline cartilage, calcified cartilage, and bone. Interestingly, the pigmentation starts off in the calcified cartilage, and then it spreads into the hyaline cartilage and to the surface, and this causes loss of bone and then eventually joint destruction. And this pigmented cartilage then breaks up because it's brittle and stiff, as I've said. So also, we've looked at the changes in the chemistry of the cartilage, and we lose something called GAGs. These are important things in our cartilage, glycosaminoglycans. And we developed this little scheme, and this is basically how we think that pigmentation happens. This is a collagen protein, which is the major constituent of our cartilage, along with the proteoglycans. The HGA comes along. It can't bind to the collagen, but then when the proteoglycans are lost, the HGA gets in there and polymerizes, turns the collagen black, and then causes further problems in the collagen around us. So it's like a seeding effect, basically. And once the pigmentation starts, it just precipitates and progresses very rapidly. So we learned a lot thanks to the donations from all of our wonderful patients who went to surgery. It was interesting. We spent we did a lot of miles going around the country picking up samples. I think South Coast, North Coast, and lots of places in between. And although we could learn a lot about the disease through these samples, what we couldn't do is test any potential agents, because, as Ranga said, it had been suggested that nitisinone might be useful, and we'd had the failed trial in the USA, and basically we were told that, we wouldn't be able to have a trial again, that nitisinone was now sort of not going to work. But we were lucky enough to find that there was some mice with an AKU defect. You can see them here. This is the AKU mouse because of the dark litter, because the HGA in the urine makes the bedding dark. And initially it was thought that these mice didn't have any of the joint complications, but in fact we found they did. So this is a knee joint from a mouse. And using this Schmoll stain, you can see these blue spots here are the earliest signs of ochronosis. Now, it never progresses very much in the mice, so we don't really see them sort of going around with walking sticks or really struggling to walk. But we can see the early stages of ochronosis. So it's a great clinical model, preclinical model. And so it gave us the opportunity to learn about where the pigmentation is, and also then to try and inhibit it. And this just shows you here that in the mouse, as in the post-mortems, we found that most of the pigmentation is deposited where tissues are loaded most. So this is in a vertebrae, and this is in something called an enthesis. This is where the Achilles tendon joins the bone. And so if we look at, in a mouse, we can do this experiment, we can look at the tail intervertebral discs, and they're not pigmented, whereas the lumbar ones, even in a mouse, although it's a quadruped, are highly pigmented. So this reinforces this view that it's loading leads to tissue damage, leads to pigmentation, leads to further tissue damage. The other thing we could do in these mice is see if we could treat them with drugs like nitisinone. And here we see the HGA is highly elevated in the plasma of the mice. If we supplement them with nitisinone in the drinking water, it goes right down. And of course, this had been shown in humans. But what we could do in the mice that we couldn't do in the humans is we could get in there and look at the joints. So what we did is we took joints like this and we counted these things. We call them pigmented chondrons. And to our surprise, even in the mouse, which we thought initially didn't pigment, we could see pigmented chondrons at an early age. And it just progresses with age. So it's a wonderful model, wonderful preclinical testing model. And so what we did is we then put some of these mice on nitisinone, and this is the natural increase in pigmentation with weeks. And if you look down here at this black cross, if we keep mice on nitisinone from birth, they don't get any pigmentation. So we knew then that nitisinone was completely effective in preventing pigmentation. And also, if we let mice become pigmented by not treating them and then start treating them in midlife, then the pigmentation stays the same once it's gone on nitisinone. So this was really good evidence that nitisinone worked, and it was part of the reason why we were able to get the funding from the European Union, which was so important in doing the clinical trials. Now, again, as you know, then nitisinone was then licensed, and of course, it was people in the NAC were treated even before it was approved by the EMA. But the one problem that we have is that we block. We block. Sorry, there's an arrow missing it. Nitisinone hits here and blocks the production of homogentic acid. But what it does is it puts the tyrosine up, and so although we've got a wonderful treatment for AKU, there are further challenges because we really need to combat this increase in tyrosine. And the way that people can lower this tyrosine is by not eating tyrosine-containing foods. Tyrosine actually comes from the Greek word for cheese. Cheese is full of it. So cheeseburgers, chickpeas, these are all high in tyrosine. And so we have to have a very restricted diet for people who go on nitisinone. Now, we can use the mice to investigate that further. So here we have, this is the plasma concentration of tyrosine in a mouse pre-nitisinone. I've called nitisinone NTPC here. Once we give them nitisinone, you can see the tyrosine goes up. Now, in the mice, just as in a lot of patients, it doesn't seem to cause an awful lot of problem. But in some patients, it does cause issues. So how can we bring the tyrosine down? Well, we know that if we give the mice diets which are low in tyrosine and phenylalanine, basically, so that's the normal diet, then we give them these ones, and these are increasingly reducing the tyrosine. Well, there's no tyrosine in these diets, actually, the phenylalanine. You can see that the tyrosine level comes down. So the good news is that dietary restriction does actually bring the tyrosine down, and I think this is shown as well in the NAC patients. But it's obviously a lot easier to study this in mice. So that's the reduction there. We can get a 50 to 80% reduction in plasma tyrosine, bringing it below a value that's going to cause any problems just with diet. We've also, I won't go into this a great deal, but we've used the mice as well to do some studies called metabolomic studies, which Brendan Norman, one of our very bright young scientists, is doing. And he's found lots of new things about what circulates in the blood in AKU and in treated AKU. But we need to develop further, further therapies. So we're thinking of developing a co-therapy to lower circulating tyrosine, and obviously using the mouse as a model for that. Or the other thing is to try and repair the defective enzyme. So that's effectively gene therapy. And Prof George Bougarius, who is also one of these experts who we've made him interested in AKU, and now he's leading this area of gene therapy. So nitisinone is wonderful, but there are further challenges. Okay, have I still got some time left, Nick?
Yes, yeah, a few minutes.
Okay, right. So one of the wonderful things about studying a rare disease is you learn things about general diseases. And while we've been studying ochronosis and the joint destruction in AKU, we've actually found some new structures. So we found these things called trabecular excrescences, these novel microstructures. And here they are. They look wonderful on these various microscopic images. But the most exciting thing we found is that when one of our patients was going for a hip replacement, and that's the hip that's come out, you can see it's not very damaged and it's got some pigmentation, but the cartilage is quite intact. But when we did some special microscopic techniques, we noticed these bumps here. And we think these are the cause of massive pain in AKU. And there you can see them actually on an MRI. So you could actually detect them in vivo, still in the patient. And this is just an image of it. And basically, we think these are part of the joint destruction in AKU. Sorry, I thought that was going to increase in size. So when we discovered these, initially we thought it was AKU specific, but now we've found them in osteoarthritis. And we actually think that it's a major cause of joint pain in people with non-AKU osteoarthritis. We got some publicity from that, not from a newspaper I particularly liked, but it was still nice publicity. And so basically the message is that studying AKU is actually helpful to society in general. Of course, OA is one of the osteoarthritis, the most common form of disability worldwide. So leads me to thank all the wonderful collaborators. And just to make the point that over the years, we've seen many of our team members gain PhDs, either people who've done it part-time, like Andy Hughes and Andrew Davison, who did PhDs at the University of Liverpool while they were busy with their jobs, working, on the AKU assays in Ranga's department. And then we've had some dedicated PhD students, all who've gone on to other universities now, and in fact have spread the AKU research to these universities. The most successful of these so far is Adam Taylor, who's in Lancaster. Obviously, I want to thank all of the collaborators here. You can see them. I won't go through their names again, but you can see Ranga's at the top of this list, and Nick is at the top of that list. And also to thank our wonderful funders. And it's because of the links with the NAC and the synergy between the NAC and in some cases pump priming from the NAC that we've been able to get these awards from the lottery and of course the big award from the European Union. And we've also had studentships from MRC. So thank you very much.
Great, thank you very much, Jim. And I'll now hand over to Tony, who's going to talk about his patient experience. Over to you, Tony.
Okay. I haven't done any slides either, so I'm just going to talk really through my experience of the NAC. People who know me know me that I sort of come from Wales, and my experience initially to do with the NAC was through contact with Leslie. I had a late diagnosis for AKU, and I wasn't diagnosed until 2011 when I was 53. And it came as a shock, but a relief as well, to actually know what condition I actually had. And after getting my diagnosis, I was put in touch with the AKU Society and had conversations with Leslie. And it was at the time when the NAC was going to be up and running and was due to open in 2012. And I had quite a few discussions with Leslie about whether I'd be willing to actually attend the NAC. And at that time, one of the conditions was you took 2 milligrams of the nitisinone as well. So I was quite happy to attend and was under the impression that I would be going once the NAC opened. But from the Welsh story, people will remember perhaps that we then had a problem in so much as we were denied really access to the NAC and also to the nitisinone. So my attendance at the NAC and the other Welsh patients was actually delayed until 2013. And the only way we could attend it was to actually attend the NAC itself, but without actually receiving any of the nitisinone. When I actually attended the NAC, obviously Leslie had talked me through a lot of what would be going on there. But when we arrived, it was to go on to the Robert Gregory unit, which was basically a ward in the hospital. And having worked in the NHS as a nurse and a senior nurse as well, I found myself reverting back to being a patient. And it was very much like being a patient on a ward and fitting into the routine of the ward itself. And in some ways that was fairly restrictive, in so much as I know my brother had come up with me to sort of keep me company and whatever, and he stayed in hospital accommodation. But because of the when you were required to go for tests and things like that, I actually saw very little of my brother. He had a whale of a time going around Liverpool and meeting people who were actually staying in the accommodation with him. But from my point of view, one of the most important things were actually meeting patients who had AKU for the first time, because I'd never had an opportunity to speak to any other patients who actually had the condition. And I was with a mix of patients, some who had fairly severe symptoms and had undergone quite a lot of surgery, and others who were much younger than me and had less symptoms. But there were 4 of us from Wales, and there was also an English patient, lady. And from when we were there, I think the 2 younger Welsh patients became quite upset because they could see what living with AKU could be like at a later stage in their lives. But being there as a group, you were able to actually talk to one another and talk through about how you actually lived with those particular things. When we arrived on the actual ward, it's like, as I said, you reverted back to being a patient, and it's like you were admitted and your medication was taken off you, and you didn't have control of your medication or anything like that. You had to fit in with the ward routine, so you were woken up nice and early in the morning. And you had your program of where you were got all the tests and things that you were going to have done, and throughout the 5 days, because it was a full 5 days when you went up there then. And I can remember my the first person I met was a cardiologist, and I can remember him doing an examination and just reassuringly saying to me after the examination, just going to me, there we are, everything's okay, Tony, apart from your heart murmur. And I just stopped and I said, but I haven't got a heart murmur. And he said, yes, you have got a heart murmur. I'm sure you've got a heart murmur. And I said, but nobody's told me I've got a heart murmur. And he said, I tell you what we'll do, we'll wait till the end of the week. And when we've got all the tests, we'll be able to tell you whether you've got the heart murmur or not. So that was a little bit of a shock to me, because the minute that somebody mentioned something to do with your heart, I think any person, when something like that said, it obviously raises your anxiety levels a little bit. But during that week, obviously, we went and saw loads of different specialists, and in a way, you sort of knew what to expect, but you didn't know what to expect. And I can remember at the end of that the week, and getting that final report, and looking at that final report and seeing all the things that had been highlighted where problems had been sort of found and things, and thinking, I wasn't aware of any of those particular things. Obviously, I was aware of the joint problems and things, but not to the extent that perhaps they were there, and perhaps how I'd been learning to live with that condition, and deal with the pain for myself. But the cardiologist came back and to me, and he said, there we are, I was right, wasn't I? He said, you have got a heart murmur. And he left the room, and I was actually with one of the other specialists, and I was having to fill a form out. And I came to a bit and it says, have you got a heart condition? And I was hesitating on that bit. And the rheumatologist who I was with at the time said, you know that you've got to tick yes now. And I was just hesitating on ticking yes to acknowledge the fact that, yes, perhaps I did have a heart condition. But the important thing about that first week was, I think, perhaps one of the most important things was the starting to build up of this network of people. Whereas when I was first diagnosed, apart from talking to Leslie, you felt as though you were on your own and fairly isolated. But then when you were there and you were with other people who had AKU, and you could share those particular things, especially as they were, you know, other Welsh patients there with you, that you were able to make contact with them even after you left the NAC, and that you had this little group of people that you could actually talk to or meet up with. And apart from that, you also had professionals as well that you could speak to, that you knew that you could actually go to. On my next visit to the NAC, it actually had moved from the Robert Gregory unit, and it was in the clinical research centre, and we were obviously put up in hotels and just attended on those on the days. And again, my brother came up with me, and this time I saw a lot more of him, because it was much easier to be able to do things, and you were able to control things like your medication, because when you were actually on the Robert Gregory unit, you were having to request medication, and staff didn't fully understand why you needed extra medication or why you had to have this medication, you know, which made it quite difficult. And I think sometimes you put up with a little bit of pain because you didn't want to have to go to the nursing staff to actually ask, could you have some more medication? But once on that, once you're based on the clinical research unit and you were based in a hotel, it made things much easier for you. All the tests were like all the same, and you were familiar with all of that. And you were able to build up even more of a rapport with the team itself. On that first visit, going back to that report that you received, which was, I think it was about 18 pages, perhaps a bit longer. And I can remember looking at it, all these A4 pages. And when I came back to Wales, I must admit, because I'm normally a very positive person, but it actually made me, I felt quite low looking at all of that. And it's one of the comments my GP made to me was, he said, it's not like you. He said, you're normally positive, you know, it doesn't matter what we tell you, you're normally quite positive. But I think it was just that initial shock of what AKU actually meant and what effect it could have on your body itself, and what implications that had for the way that you carried out, the way that you ran your life, basically, and everything. I can remember taking that report back, and at that time I was teaching, and I took it to, I said I needed to take it to the occupational health department because it was useful to have that, just that document. And I can remember taking it to them and having the appointment, and the doctor looking at it and opened it, and she said, I'll go and get the forms for you. And I said, what forms? And she said, for you to finish. And I said, I don't want to finish. And she said, but with all of this, she said, I normally have people come in with, and pointed at one of the things and said, just seeing that, and they'd be wanting to finish. And I said, but I don't want to finish. And she said, that's good. I'm glad, she said, right, we'll sit down and we'll work out a plan of action for you. So that actually gave me a basis to actually work on with them, to actually put things in place in work to help to facilitate me to stay in work for a much longer period than perhaps I could have. So that was one of the real benefits from it. And another benefit was actually being able, that report going to my GP. Now I know I'm lucky, I've spoken to other AKU patients, that I've got a very supportive GP. In fact, he's incredibly supportive. And whenever he knew that I'd be going up to Liverpool or attending the NAC, he would make a double appointment for me to go back to see him, to go through the report with him. And we discussed through it, and he would ask me what bits I wanted to action on it and in what order. And we would come up with a plan of how we would do things. So by having that report from the NAC, gave a good base of where I was actually going from. And having the report like that as well from it, because I had several admissions to A&E, and I actually gave them a copy of the report to put into my folder so that they had the information there. So whenever if you had to go in, they had the up-to-date information. The experience as I say, on a clinical research unit was much better experience, really. Just in so much as the time that you had that you could use it and be far more flexible, and you didn't feel that you had to stick, rigidly to perhaps staying on the ward or being back by a certain time or things like that. I actually only attended the NAC for a couple of years before I went on to the clinical trial. But again, we still attended the clinical research unit, and we still met with the same staff and had more or less the same sort of tests. So it was the same sort of experience. The only advantage with being on that clinical trial, it obviously gave me access to a much broader range of patients and meet up with patients who were from abroad and listen to their experiences and how things were in the countries that they lived in and things like that. After finishing the clinical trial, I then attended the NAC again. And by that time, they'd reduced down the number of days that you attended, which I think was a good thing in a way, because that initial 5 days was quite tiring doing that. It was a long 5 days. And although the days have been condensed down, it's still quite tiring, because some of those tests that you undertake, actually, because of the pain you're in and the impact it has on your body of undergoing some of those tests, can make it quite exhausting for you. And the thing about that is, what I found over the period of time of attending the NAC is the expertise of the staff who see you has grown as well. So that when you're actually seeing specialists, it's really nice to actually see people who you don't have to explain what AKU is. You don't have to explain what you're going to be going through. You don't have to explain, well, I could be in a bit of pain if you try doing that. They understand, because they've been in contact with people and various people. And lots of people, I know I'm one of the fortunate ones, because I've not had to have a joint replacement, but I know other people who have had multiple joint replacements and the impact that has on them. So by attending the NAC, it just gives you that experience as well.
Excellent. Thank you very, very much, Tony, for that. And thank you to everyone. So just to wrap up, I'm going to talk a little bit for just a few minutes about some of the upcoming work that the AKU Society is doing, along with the NAC and the University of Liverpool. First of all, to remind you all that we have our patient workshop in Liverpool on the 4th and 5th of November. That's Friday and Saturday. I think it's actually on the Saturday, but I think we're coming up on the Friday. But anyway, we'll be able to provide further details on that. And there will hopefully be an international patient workshop maybe next year, potentially also in Liverpool. The other thing is this year is actually 10 years of Leslie working at the AKU Society with the NAC. So we really want to thank Leslie for all the work that she's done, which has been just awesome. We are working with the NAC and with Milad on developing a patient registry. And there's further information there that will come out soon. And we did a crowdfunding campaign for that last year. We also had our scientific meeting in Brussels in May this year, which was funded by the European Joint Programme on Rare Diseases, where there was a lot of presentations about all the science and the work that's been doing, and that went really well. And we're now applying for funding for another workshop, hopefully next year. We're going to start working soon on a new website for the AKU Society, which will be very exciting. On nitisinone, we're now really pleased that every single European country, apart from Romania, the patients there now have access to nitisinone for AKU. And as you heard, also in the UK, Wales recently approved it, Northern Ireland did, so it's now accessible to all patients in the UK. That has been a huge work over the past 10 years. And really thanks to Sobi for helping with us all that. And our sites are now on the US, where the AKU Society North America that we're involved with, and Cyclepharma, which is a generic nitisinone company, working with the NIH to try and get nitisinone there approved by the FDA. You know, and then recently we did a presentation to the government's Rare Disease Advisory Group. Professor Ranganath, Dr. Khedr, and myself talked to them about the success of the NAC, which was really well received, you know. And so, yeah, so overall, you know, thank you to everyone who's working at the NAC. Thank you to everyone at the University of Liverpool and all that for the work that's been done. And, you know, if you have any questions, please do ask them now. And we will provide this recording online so that patients who couldn't attend can actually find out more about what we've done. Thank you. Brenda, Tony, were there any more questions from your side? No? Oh, Brenda, go on. We can't hear you, Brenda.
I've done it now. Just one that I've thought about. You know that the babies with PKU, they have the heel prick test if they've got it. Would that be possible to do it for AKU, or is it just too expensive?
Well, that would be for Milad and Ranga to answer, because newborn screening, I think, is a great idea personally. And anyway, over to Ranga and Milad.
Milad, shall I go first? Or do you want to take this? Okay, I'll start. I mean, one of the things about the newborn screening program is the heel prick, where they use a blood sample. Of course, you probably know that you guys are also doing finger spot analysis for monitoring the tyrosine. One of the questions we're still not sure about is whether we can measure homogenetic acid in the spot. Because homogenetic acid is different from tyrosine. It seems to bind to the blotting paper, and there's some suggestion that we can't measure homogenetic acid reliably on the blotting. So that is probably a barrier, but we haven't investigated it. And of course, 2 or 3 years ago, I did make contact and find out how we are going to think about newborn screening program. Because you're right, because one of the criteria for screening a newborn for disease is that it should be treatable. Of course, now it is treatable. And of course, Jim has shown that if the earlier you start nitisinone, the better. But the problem with nitisinone, you can't treat very early in AKU because of the possibility of high tyrosine causing brain problems and all the rest of it. So to answer your question directly, we are thinking about newborn screening, but we will need how we do that.
Okay, thank you.
I hope I answered your question there.
Yeah, that was great. Sorry, I accidentally hit the recording stop and resume there, so so there's going to be a little bit broken up, but that should be fine. Great, thank you. I see, Milad, did you want to add anything, or are you okay? Okay, I think that's probably okay. Nina, thanks for joining. Good to see you. You're unfortunately just at the end. We've just finished, but however, we have recorded this. So we'll be putting it online for all patients to be able to watch. So thank you everybody for this. I'm going to stop the recording now, and we'll see you
sorry,
soon.
I've been on holiday and I just...
Good to see you, Nina. Hi, how are you?
Yeah, well, I'm coming on Sunday, so I shall see
Good.
Great.
you then.
Yeah, see you next week.